into the main things for the size or for the drugs. What I will say about this is when you're studying these, it's easier to study them by class because once you kind of learn what's going on for that class, that mechanism, most of them have the same adverse effects, but they're all going to have the same mechanism of action, okay? So this is, again, one of the ones where I would group by class. So remember the main things that we're pointing out, those weird adverse effects that you're going to see, the mechanism of action, adverse effects, drug interactions, and now when we start talking about antibiotics, a big thing that we're looking at is allergies. Is somebody allergic to that class? Because if they're allergic to that class, I can't give it to them again in certain situations. Or if they're allergic to this class, they may have cross reactivity or allergies to another class that is similar, okay? So we're gonna go through this, talk about resistance and just a lot of basics in our part 1, okay? All right. Oh, it's skipping stuff? Okay. So your ELOs, same things that we typically see, mechanism of action. So looking down there at the bottom, those are the big things that I want you to focus on. Typically with drugs, pathophys, I don't really test you on. There's no pathophys in this part of anything. So this entire slide deck is available as being a question on an exam, okay? I just want to let you know what we're looking at. Okay, so what is infectious disease? Why do we need it? All of the good things, right? So essentially when we're talking about ID, which is what we call infectious disease, we're talking about bugs and drugs, okay? Something has caused someone to become sick, whether it's a bacteria, a virus, there's several different things out there. We then have to figure out what drug we can use to defeat or beat that bug. Here are some different guidelines that you can look at. IDSA is very good. And also when we're going through this, if you see them underlined like that, that's like a hyperlink where you can click it to use it later, like as a resource. I'm not gonna ask you any of that like specific detail for the exam, but this is for you to look at later. But I need you to know what resources you have available because that could be a question. What resources can you use? So looking at your apps, Stanford Guide is very good. There's several different apps that you can use and put on your phone. Also, if you have that LexiDrug, Lexicomp, like make sure you have that downloaded because it's very good. There's gonna be so many antibiotics, it's gonna be hard for you to remember initially, and as you continue to use them, it becomes less overwhelming, okay? Initially, it feels very overwhelming. So I kind of touched on this already about what can cause someone to be sick, what can be deemed an infectious disease. So you have bacteria, we have viruses, we have fungus, we have parasites. So we're looking at all of these different things, which is what we're gonna do all of our lectures on. And we're gonna say, hey, how do I treat or how do I kill that bug? Okay, what drug am I gonna use to kill them? This is just some basic terminology of things that you're gonna hear. So when we look at chemo, this is just thinking about like the cells and us trying to eradicate those cells from that patient. When you see a patient who is on chemotherapy, you should automatically be thinking like they're likely immunocompromised from our chemo. Like they're wiping out so much that they're immunocompromised, meaning their body isn't going to be able to fight how a normal person's body would be able to fight, right? So a little small bug that we could typically handle, it may make them very sick, okay? So when you see chemo, think about them being immunocompromised. Your antimicrobial or anti-infective agents, that's just anything that is gonna kill that bug, okay? I'm trying to get rid of whatever that microorganism is. And then you have different categories, which are things that we'll talk about, like your antibiotics, your antivirals, so on and so forth, okay? And then when we look at the bactericidal, bacteriostatic, we'll talk about that because that's dealing with our antibiotics. Is it killing it, which is your cidal, right? Bactericidal is saying it completely killed it, versus your bacteriostatic is like it's stopping it from growing, but it's not killing it off how we would want to. So sometimes we will use these two things together, a static and a cidal, to get rid of something if we want it. So that's called synergy when we use those two things together. So we'll kind of go over some of those things. looking again at our cytal is me actually killing something, whereas my static is me slowing down the growth of whatever that microbe may be that we don't want. So this is giving you, if there was no drug and you had a bacteria and it was just growing in your body, your patient's becoming sick over time, right? As time continues, the growth of that bacteria is increasing. And then you say, all right, I know that this person is sick. I find out they're sick right here. And I want to give them a medication. I give them that bacteriostatic drug. You see that it's not dropping down. There's just no new growth happening. Whereas if I give them that bactericidal drug, I see that I'm not getting any new growth and I'm killing what was there. So then the bacteria level starts to decrease again. So when we have our patients who start to feel better, that's because we're seeing this kind of starting to happen. But if they stop taking their medication, if I'm not all the way down here at 0 and I'm here, that bacteria is gonna go whoop, and it's gonna start growing again and multiplying again because there's nothing there to continue to kill it, all right? So that's why we tell them, hey, you're gonna finish your medication. It's important to finish your meds. So when we're looking at kind of which ones we would pick, again, when you're looking at this, just remember the definition of this more so than trying to say like, oh, I have this patient who is immunocompromised, I should pick something that's cytal, which is typically what we do, because their body can't fight anything, right? So you giving me a head start, so to speak, with a bacteriostatic drug is not going to be good enough for an immunocompromised patient. I don't have the weapons to beat this bug. So I need you to completely kill it with a bactericidal drug versus giving me a bacteriostatic drug, which is giving me a head start, but I can't complete it because I don't have anything. So that's where you see like your patients who have any type of immunocompromised condition. Also, when we talk about endocarditis is very hard to treat. It takes us a long time to treat it, 4 to 6 weeks, sometimes even longer. So when you're looking at this, you don't want to mess around with those bugs essentially growing on and destroying that person's heart. So we go in cytal like guns blazing, okay? We're trying to kill everything. And then again with your static, for your uncomplicated infection, so when you look at the slides as we go through, you'll see all of your ones that are going to be used for like your static drugs, your clinical uses are going to be like less serious things, okay? But our cytal, you're going to see that we use them for lots of things, but they're like your more serious, difficult types of infections that you're trying to treat. Immunocompromised, we already talked about this. Your selective toxicity. So this is ideal if we had like the perfect antibiotic. It would only kill that bug and it wouldn't touch my host at all. That would mean that I didn't have any side effects. We know that that's not typically what happens, right? We try to balance the effectiveness of that drug with limiting the amount of exposure to that host, but sometimes, most of the time, we can't do that and we're gonna experience something. Okay, so that's the selective toxicity. MDROs or multiple drug resistant organisms. Those are gonna be our organisms that are resistant to several different classes, sometimes 2 to 3 different classes of our drugs that we have to kill our bugs. This is becoming more prevalent, which is why we're trying to make new antibiotics, or now our old ones don't work as much. So we'll talk about antimicrobial stewardship because that's a big deal. We're trying to decrease the amount of MDROs that we have. Your pathogens are essentially your bugs, right? What is causing my issue? And then your SSTI, you're gonna see this abbreviated a lot, will be your skin and soft tissue infections that we'll kind of look at in like super briefly. I'm just telling you the drugs, y'all will get a whole lecture about your SSTIs. Empirical treatment. So when we talk about empirical treatment, let's say that I was sick, I came into the hospital and you didn't know anything that was wrong with me, but I'm super sick. You get labs, I have a fever, white count, like I'm giving you signs that there's some type of infection. Before you give me any type of antibiotic, which you're likely going to put me on, you need to pull my labs, okay? You send that off to the lab, you're trying to figure out, hey, what bug is getting this person sick? You will start with empiric treatment because you don't know what bug. Okay, so this is like if you were fishing and you're trying to catch as much stuff as you can with the widest net possible. This is your empiric treatment, so that you can kind of be like, okay, I know that this person, or we're having an outbreak of this at this time in our area. It's likely that it's this because our patients typically are presenting this way, so I'm gonna give them some empiric treatment, and then in a couple of days, your labs will come back, and then you'll de-escalate that treatment and focus on that drug or that bug that the lab told you was causing the infection, okay? So broad net first, your empiric treatment, and then you'll get your labs back, and then you'll taper it down. So you're gonna go from this to this, because now you know the bug. And we're always gonna get our labs before we give that antibiotic. Why? Right? If I give you the antibiotic first, it may make it more difficult. Not saying that all of that bug will be gone with one dose of my antibiotic, but it may make it more difficult for me to treat my patient now because I decreased that bacterial load. So get a clean, like, this is how they came in, let me get my labs, and then give them their meds, okay? It's not that much of a delay for you to do that. Your antibiogram, this will vary depending on where you are. So like what we have here in San Antonio may be different than the bugs that are going around in Austin, which may be different from the ones that are going around in Fort Worth, okay? Like everybody is different. So different hospitals will have their antibiogram, and that will show them locally, like, hey, what is my resistance or my susceptibility pattern look like? What am I fighting here? What bugs do we typically see that are now beating my drugs and I need to go to something else? And we'll look at those. And then your minimum inhibitory concentration, or your MIC, when you get your labs back, we will look at an example of one, but when you get your labs back, they will have your MICs on it. And essentially that's like the lowest dose that you can use to kill whatever that bug is. You're trying to stop the growth. You'll see susceptible, intermediate, and resistant. We love seeing susceptible, right? That means I give a drug, my bug is getting killed by that drug. We're likely to see great results. When you see intermediate, it's kind of like, meh, hit or miss, okay? But when you see resistant, that is where we're worried about the fact that now my drug is not gonna kill that bug. That bug is like, I know your playbook, not gonna work on me, bye-bye. And then the drug is not effective, okay? So our resistant is where we're worried. You can typically see this on some of your labs that you get, like you may see one or two, but you'll have several other options where you'll have susceptible or you'll have intermediate, which is fine, right? You just don't use the drug that it's resistant to, okay? All right, here is an MIC example. So what we were looking at was, when can I stop that bug from growing? And so what they do is they put it in what's called a broth dilution test, and they'll put a sample in there, and then it's in there with the drug, and they're trying to see, all right, when does that bacteria no longer replicate? When does it stop growth? So what is the MIC of this antibiotic that we have up here? 1, right? So that's how they're reading that. So when you see your lab results, it's gonna have those MICs on the side, which is what you see right here. So this is telling you, like, hey, your MICs are gonna be anything that's over these numbers that are listed here. This is what I was telling you about. So don't look at these drugs. This is bless you, I think. These are different antibiotics. Now, all of these are not in the US, so this is just an example. I don't need you to remember the results. I don't need you to remember MICs. I just don't want you to remember how to read this. So they had a patient who came in. The patient was sick. They got their labs, right? They sent it to the lab, and the lab isolated Pseudomonas. Okay, that's the bug that was causing that person to be sick. Okay, so that's their isolate that they have. And then they will give you all of these antibiotics that you can use to treat that bug, okay? And then they're gonna say, hey, this particular bug that this patient has, either they're R for resistant, I intermediate, or S for sensitive. And then it goes down the line to tell you that. So here you see like, oh, I can use ceftazidime, I can use my piperacillin, ticarcillin, or my tobramycin because it's sensitive to those. I'm going to prefer sensitive over intermediate, right? Because that's hit or miss. It may or may not work. Resistant, I'm not even looking at those because I know that they're not gonna work. And it's great when you're actually in the hospital and you're practicing because it essentially tells you what antibiotic you're gonna use. You will call your ID department if this whole thing came back. I got you. If the whole thing came back and it said resistant, that means you have something that's definitely an MDRO, and you're gonna need to get the IV or infectious disease department involved. They have docs, they have pharmacists, this whole team, and then they have also privileges to prescribe drugs that you may not have access to prescribe. Yes?
Just to clarify, ma'am, so let's say like we draw specimens or like blood cultures or whatever to see like what the bacteria is. So does lab automatically do the MIC, or do we have to specifically request for them to do it?
They do it. I have not seen an instance where I got this back without it. So they typically do it. Most of the time when you're doing this, and you have a patient who is gonna be on any type of antibiotic, if you have an ID department, they're looking at every single patient most of the time that's in the hospital. So if you did end up picking the wrong drug, most of the time your IV pharmacist or one of those docs would be in there like, we need to switch this. They'll call you and figure out what you did. But most of the time, all of this information has been on everything that I have ever seen. And it should be, because it's when they're pulling it in the lab, it's easy for them to just input all of that. Yes?
Would you like check this that tobramycin would be that's what you use?
It's the lowest one, yeah. Like you're not giving that patient as much of a drug. You can give them less of a drug. Now, when we look at this, I shouldn't say as much of a drug, because your doses are gonna be either weight-based or they're gonna be a standard dose for whatever that isolate is that you found. So it's just letting you know that you're more likely, you're gonna have a greater effect of killing that bug with your lower MICs. So yes. Okay, this is your antibiogram. So when we're looking at our antibiogram, remember this was the thing I was telling you that will tell you, oh, I have resistance to this bug. So the way that we're reading this is here are all of the different bugs that they have for their gram-positive that they were looking at. And then they are like, okay, I'm gonna run it against all of these antibiotics to see if it's likely to be susceptible or not, okay? So you know how whenever you go to the doctor or if somebody's sick and they're like, have you traveled outside of the country or have you been traveling in the last 2 weeks? That's because if I went somewhere else, that whatever infected me may not be the same thing as what you have information about. So that's why it's an important question to ask people, because now you're trying to figure out, I wonder if there's something else going on over here or there's resistance over here as to why what I would typically use may or may not work. Okay, so that's why they're asking that question. So bug and then your drug. So if I were to ask you about strep pneumo, what would you say is the best drug to use for strep pneumo? Right? My ceftriaxone, because I have a 98% with my susceptibility. So it is very likely to be killed if I use my ceftriaxone. All right? Typically, and it depends on where you are. Some places have different cutoffs as to where they would allow you to safely prescribe a drug. Now, sometimes your susceptibility is gonna not be fantastic, right? So you'll have some where you'll get susceptibilities and they're all in like the 80s or the 70s. And it's just like, this is what we have to use, which is why we're gonna talk to you about antimicrobial stewardship so that we can decrease the amount of resistance that we have. Because as our resistance increases, these numbers start to go down. And our drugs that we have available to defeat these bugs starts to go down, okay? And then we have people sick, and then they will die from the infections that they have because we don't have the drugs to treat those infections. What was I gonna say about this? Every year, you should see a new one come out of these, right? Because things start to adapt to what you have going on. Oh, you're gonna keep using, you're running, thinking about football or something, right? You're running the same play. I know what I need to do now. When I'm on defense, now I already know what your playbook is. This is an easy game for me, okay? So as we continue to use antibiotics or overprescribe antibiotics, these bugs are morphing as well. And they're like, okay, I already know. And then they make resistance mechanisms to those drugs. To where as soon as we put them in our body, those bugs come and they will inactivate my drug. And they're like, not working today, okay? So this should be changed every year. And then that's how you're going through and reading it. So I could say, hey, here's this bug, whatever this bug may be, and I would be like, all right, which one is the best one for me to use? So if I were looking at enterococcus, I can use miladeslid or I can use Bane, two good options for me to treat somebody who has an enterococcus infection, okay? I don't need you to remember all of these numbers because if I want you to read an antibiogram, I will give you a picture of the antibiogram. I just need you to know how to interpret it, okay? So just like what we did, bug, drug, susceptibility. And then that's what I was telling you. Some places they'll tell you like a cutoff. So they'll say like, hey, if you see anything that's below 80%, and if that's all that you have, contact the ID department and let us try to deal with it. Let us follow that patient because it's likely that maybe this drug, like they don't like the 20% chance that it won't work. So they like to follow those patients also. So again, that cutoff will vary. Just, I need you to know how to read this, how to interpret it, and that you're getting a new one every year. Okay, you're gonna have access to a lot of antibiotics and you're gonna be like, how am I supposed to know what to do, okay? The first thing that you're doing is you're gonna get your labs because you need to know what you're fighting. You need to know what you're up against, okay? So you'll get your labs and then you're gonna look at your patient and say, all right, I have this result back, or I'm doing empiric treatment because I don't have anything back yet. But I have this result back after I went from this to this. Now I need to make sure that I am taking care of everything possible because there's so many different factors that go into picking the right antibiotic, and that's just the name of the game, okay? So this is more so an art. It's seeming, for our exams and for class, it seems very straightforward. When you're out there and you're trying to figure out what to do with a patient or their antibiotics aren't working, it becomes you kind of like plugging and playing, like, okay, that didn't work, I need to do this. Let me make an annotation of this. Oh, they had an allergic reaction to this. Okay, let me annotate that so that I know not to give this to them again. So it becomes you like, all right, what do I need to do adjusting to the result that you're getting from that patient at that time? So, medications. When we look at our drugs, is it gonna get to the site of infection, right? Everything may not be able to penetrate and get into the CSF. So if I have an infection in my spinal area or in my brain and that drug can't cross to get to there, it's not effective, it doesn't work. So you got to make sure, can my drug get to where I need it to go? Is my person allergic to it or not? How long do they need to be on this medication? How frequently do they need to take it? Does that fit in with what that person has going on? Looking at your need for multiple agents. This is like that synergy that I was telling you about before, right? Where I may use a cytal and a static drug together, or I may use something that will help me get through the cell wall, and then I go in and I can tear up the ribosomes or everything else that's on the inside to kill that bug. So sometimes we double team the bugs, and sometimes just one drug is good enough to kill it. Your pathogen. So looking at this, we talked about this already. Make sure you get that lab before you give any type of antibiotic so that you can get a full picture. The gram stains, y'all talked about that already, but that just kind of helps you be able to define the bug. You're not going to do that. Lab does all of this stuff for you when you're looking at like this pathogen part of it. And then the risk for resistance is like looking at that antibiogram, just looking locally at what you see like happening and what trends you all have at your hospital. Your ID department will be very good with helping you with this if you're not sure about it. And then your host, I kind of been talking about your host while I was talking about your medications already, because it kind of all blends in together, right? Do I want to be in the hospital? If your medication is only available IV and I said I need to go home, so we had a patient, she had been in the hospital for like 2 months. And her son was graduating from high school, and we had her on IV antibiotics. And she's like, well, I am not missing the graduation. Like, I have to go to the graduation. I've been here, I let you guys do all this stuff. And we couldn't figure out, like, she was resistant to like everything. And so we came to an agreement that she would be able to leave the hospital, and we come back and let her get an infusion again of the antibiotics, and then leave again and come back, because she had been there for so long and it was a big deal for her, right? So now I'm trying to figure out, all right, is this person, do we have IV access? We have access, but the patient doesn't want to be here right now. And she can leave, they can leave. So it was us trying to work with her to make sure that that 2 months of all of the time that we're trying to get her better didn't go to waste, right? And then we had to start all over. So sometimes you have to get creative with what you're gonna do. On some patients, they may wanna do what's called OPAC, where you can get them their infusions at home. They don't have to stay in the hospital. You see if their insurance covers it. But we can do where they get IV infusions at home. They send out a nursing team to those patients. And then looking at like if they're pregnant or they're immunocompromised, all those things kind of help you pick what antibiotic you're going to use, because some antibiotics you can't use in pregnant patients, okay? So just going through this, understanding that there's several things that we're looking at to pick an antibiotic. Allergies. Please, 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 when you have your patients come in, make sure that that med rec was done, and make sure that you have updated their allergies properly. There are some people who will come in and say, oh doc, I had diarrhea. I can't take this med. That is not an allergy. That is a side effect of the med, right? Like the drug caused it, and usually when we're talking about antibiotics, it'll wipe out all of their good bacteria too, and so a lot of people will experience diarrhea. Don't put that as an allergy, okay? That was a side effect that made that person uncomfortable, and like I always like to tell y'all to remember, but did you die though? Was it anaphylaxis? Anaphylaxis, hives, big things like that, those are the things that you're gonna annotate. And when you put it, don't just mark, oh, amoxicillin, that there's an allergy, and not put what happened. When you put what happened, the next person behind you can say, oh, they almost died though. They had like anaphylactic shock. I'm not touching that. Versus, oh, they just were itchy a little bit, right? I may be able to say, oh, they were just scratched, let me give them some Benadryl, and I'm still gonna give them this drug of choice that I want to use. Versus if somebody had anaphylactic shock, most of the time, you're avoiding that. You're not gonna give that again, okay? So when you're documenting, make sure that you're putting what the reaction was. If you see an allergy in there that does not have what the reaction was, ask the patient, hey, do you remember what happened when you took blah, blah, blah? Oh, no, I was a kid, my mom just told me. Is it possible for you to reach out and see if your mom or your dad still knows what, and see if you can complete that record, okay? Because what will happen is you will try to go and prescribe a med, and then it's gonna block up and come up and say, oh, the patient is allergic to that. And until we fix those profiles, it's gonna continue to do that. It's gonna do it on your side, and it's gonna do it on the pharmacy side, because nobody ever cleans it up, okay? Renal function, hepatic function, you'll see this when we start talking about a lot of drugs, and we'll say like, oh, there's renal clearance or hepatic clearance. So if I have any issues with that, right, now my drug levels are gonna be affected by me having renal issues or hepatic issues. I may have to look at my package insert and say, oh, I need to dose adjust this one, versus, oh, this one is fine, okay? So that's another thing that comes into play, and then we already talked about the pregnancy and lactation. Remember breastfeeding moms also, because if they're breastfeeding, sometimes the medication can go through that breast milk to the baby, okay? So just keeping that in mind as well. PK factors, so when we're looking at our route, we know by what we were talking about with our ADME and all of our stuff in our PK lecture, right? My IV is hitting, I'm typically getting all of that dose. Best thing, right? Most effective thing typically that we have. But it's not convenient because I have to be in the hospital or I have to pay more for like those OPAT services that I was telling you about. So looking at the route is something that's very important, and then you also have your distribution, right? Making sure that it's getting to where it needs to go is essentially what this is saying, which is what we already talked about. So we have certain drugs. Remember, our brain is protected by that barrier. It's trying to say like, no, you don't belong here. There are certain drugs that can still fit through that blood-brain barrier. So in that situation, if I have any type of infection like meningitis, I have to make sure that my drug can get to that site. If it can't get to that site, it's pointless and I'm gonna die. And I don't wanna die. Thinking about that too, would I pick a cidal or a static drug if I had meningitis? It's in my brain. Cidal, right? If I don't kill it, it will kill me. Okay? So like your super serious infections, if all else fails and you remember what is cidal versus static, you're going to pick a cidal drug. Okay? Because you're not trying to let your patient die. So if it's something that's super serious, anything in the head, typically we are picking a cidal drug. Toxicities. When we look at toxicities, again, we try to have like that perfect balance, right? We try not to harm our host, but we know that with every good thing, we have some bad things. So when we look at toxicity, most of the time this is going to be due to us giving a higher dose, or if somebody has a renal issue, one of those hepatic issues that we talked about. So when we look at these, typically with your vanc and your aminoglycosides, the higher the doses that you give, you're likely to see that nephrotoxicity occur. And then your photosensitivity, you have your fluoroquinolones, tetracyclines, sulfonamides, bless you. With these, what you're essentially telling your person is they're likely to have a sunburn a lot easier if they're taking one of these medications. The longer that they're on the medication, the more photosensitive they become. So sunscreen is a big deal, protective clothing is a big deal, just trying to stay out of the sun is a big deal. Because the sunscreen sometimes is not enough and they will still burn, okay? Especially because most people, we don't put on sunscreen as often as we're supposed to. So sometimes what you'll also see from that photosensitivity is like their skin will get darker in some areas because of how easily, how sensitive their skin is to that light. And then we have diarrhea or colitis, which is C. diff, what we typically call C. diff. And our biggest offender that we have for this is clindamycin, which is a good drug, but the C. diff is so bad that we don't love to use it if we don't have to use it, okay? So it's a balance of all of these things. You're trying to figure out what bug is causing your issue, and then you have a plethora of drugs, and now you're trying to pick which ones to use. So patient factors, all of these things come into play. Okay, when we're looking at our concentration versus our time-dependent killing, this is just kind of trying to think of what we, so remember in our PK lecture, we talked about when we were giving multiple doses until we got to steady state, we kind of saw that it was continuing to increase, right? When you're looking at this, this is trying to say, I found my MIC. When I'm in that therapeutic range, I'm saying that I should be above my MIC, right? Because in my therapeutic range, my drug is working. So remember when by the time we got to steady state, we were maintained into that therapeutic range. If I fall below that, I'm not in my therapeutic range anymore, and I'm typically below my MIC, okay? So when you see this, this is saying when you're talking about concentration dependent, the higher the dose that I give somebody, the more effect that I'm gonna have in killing that bug. Remember, higher doses are also coming with more side effects, right? So this could be something that's also like a loading dose, but some of our drugs will have them on the higher end of that therapeutic window, not in a toxic range above my therapeutic window, but we'll have it like on a higher range because the higher my concentration, the more likely I am to kill my bug. And then when you're looking at time dependent is saying, hey, how long am I over that MIC is more important. Okay, so I don't wanna fall out of that therapeutic range. So therefore, I'm gonna continue to dose before I fall out of that range. I wanna stay in that window. So this is just looking and saying like, how long am I above the MIC versus how much, okay? How much is concentration, time is how long, okay? So when we're looking at this is just showing you the dose dependent. So you see here, with that MIC being that 64 over, because remember I said 4 to 64 over, you see that it increases, the rate of killing increases as the concentration does. That's what we're looking at here. Versus here, this is looking at the time over the MIC. So the longer that I can stay over, the more killing I'm going to see in this. And this is just a picture showing you the two. You don't have to remember this at all. Just know that you have concentration and time. Concentration, you want to have that drug be over that MIC. The higher, the better. Whereas your time dependent, you want to be over that MIC as long as you possibly can to kill as much of the bug as you can, okay? And then this one is looking again at that time dependent killing. So here you see that they gave a dose and then they said, all right, they haven't redosed this patient. So this was just calculating it and saying the time above this MIC was about 9 hours. Whereas on this one, I'm giving them several doses. And you see right when I fall below the MIC, I'm like, oh wait, I need another dose. Oh, I'm falling below, okay, I need another dose. So each of these peaks that you see is another dose. And now you see that I have about 15 hours over that MIC. Therefore, I had greater killing of that bug. I killed more of my bug, okay? So that was more beneficial because I stayed over my MIC for a longer period of time. Everybody okay? Y'all's faces are giving me the face. How we doing? Yes? Yes or no? Yes, okay. Okay, now, when we are looking at this was what I was talking to you guys about the synergy, right? If I can combine something together to help me kill that bug, I need help. So maybe you're helping me get into the cell so that I can go inside and work on ribosomal killing because we have different targets of our antibiotics. So I could say like, hey, let me use this beta-lactam so that I can break down the cell wall so that I can allow my aminoglycoside to come in and do the work that it needs to do on the inside. Because my aminoglycosides aren't affecting the cell wall how my beta-lactam will affect the cell wall. So if I can't get in as the aminoglycoside, I can't work, right? So therefore my drug isn't getting to the site. Remember we talked about, can that drug get to the site? It can't get to the site to do its function. So therefore I use these two drugs together to work. When you're looking at this broad spectrum, this is again casting that wide net. I know that my patient is sick. Do I know exactly what's wrong? No. You'll have traumas, you'll have certain things, and we're like, we don't know what's going on. I'm gonna probably put them on some Vanc, some Zosyn, depending on what's happening. Like, I'm just casting this net because I have no idea what's going on. So I'm like, labs, I get my labs, antibiotics. Until we can go from this to this, I am broad spectrum. I am getting my drugs that have the most coverage, like, hey, what drug can I find that's gonna have some gram-positive coverage, it's gonna have gram-negative coverage, like, I don't know what I'm fighting, so I'm just being very broad. So you have broad spectrum antibiotics that you're using whenever you're doing your empiric treatment. Empiric treatment is typically gonna have more than one drug that you're using. Because again, I might have a drug that has a lot of gram-positive activity and it can kill a lot of my gram-positive drugs, but it's not so great at my gram-negatives. So now I'm gonna be like, hey, I need something that's also gonna focus on this gram-negative also, right? So now I'm using these two things together in my empiric treatment, right? I cast my net, now I'm broad. And then sometimes, not all the time, but sometimes you'll get those results back and you can say, all right, I can take one of these off. Or I can take both of them off and I can now taper it to something that's not broad. I know what bug I'm fighting, now I just need a drug that's covering that bug. Okay, so then you can take them off of a broad spectrum antibiotic as well. Okay. And then looking at this is just different situations as to why you would need multiple agents. If something is resistant, right? Now we need to double team them. Okay? Because we can't fight one-on-one. Now I need somebody to come and help me. Right? Because you're very resistant, you're strong. Think about resistance as being strong. They're smart, they're playing chess, and our drug is playing checkers. Okay? Our drug is behind, it's going to lose. All right? So we need help. So that's why we'll put on more than one drug, or we'll get a stronger drug. Okay? And then decreasing the toxicity. We will sometimes do this if we're saying, hey, I need to combat this in a different type of way. I don't want to increase my dose, because I increase my dose, I can potentially get outside of my therapeutic window, bad, right? So let me use these two drugs together. I can keep them both in that window, and they're both targeting this drug, this bug that I'm trying to kill, okay? So we have several reasons as to why we can use multiple drugs and not just one. This is just the example of what I had talked you through already. So you have penicillin, which is a cell wall inhibitor, and then you have your aminoglycosides, which work on the protein synthesis. This cannot get into the cell if it was just by itself. Your penicillin can't do anything to the protein synthesis by itself. So if you just use your penicillin, you would have cell inhibition, but you're not going to have like the actual death that we would want to see of that cell. Now, if I use this together, penicillin is like, hey, I'm gonna knock down the door for you, aminoglycoside, you go in and you finish them off. So the penicillin breaks up that cell wall, and then aminoglycoside is like, thanks. It goes in and it starts to work on that protein. Okay? So they work synergistically together to defeat the bug. Right? Disadvantage, though, is that you can have two drugs that have a mechanism that kind of crosses over each other, and so they're antagonistic to each other, to where they're working against each other. So that's kind of where you're seeing, like, I can have a bacteriostatic drug, which is slowing down the growth, but I have a cytal drug, which needs the growth. So if I slow it down and it's not dividing as much, now my cytal drug doesn't see any activity that it needs to go kill. So now you're having these two things work together, against each other, antagonistic, okay? So this is looking at your tetracycline, giving you an example. So your tetracycline is gonna slow down your cell growth. And then if you had something that was a cell wall inhibitor, so your penicillin, we'll talk about some of our beta-lactams, it needs that growth to work. So if my tetracycline has stopped the growth, now my penicillin can't do what it was supposed to do. So that is sometimes where we'll have these things kind of butting heads, and it's not a good thing. Okay, so then it becomes antagonistic. If you have questions, if you have a patient who's on a lot of drugs, always just run your interaction checker. The big ones I want you to remember, because I want you to be like, oh, I know that you can't do that. And I also want you to be aware of it's a drug like warfarin, digoxin, like some of those drugs that have interactions with everything. I want you to remember, hey, I probably should run this. I need to check this, okay? Y'all have talked about gram stains and all that good stuff already, so this will be pretty quick. Remembering that you have your gram stains that you're doing so that you can identify what your bacteria is. Gram positive, gram negative, is it ROS, is it cocci, what's going on with my bug. So when you're looking at the gram positive and gram negative, what color was your gram positive? What color did it stain? Purple. Okay, then we have our aerobic, our anaerobic, our fat-lived anaerobes. We'll talk about this a little bit because some of our drugs will work in certain situations and not in others. There'll be natural resistance. And then our sensitivity. So remember I was telling you, you're gonna get those labs when that patient first comes in. but you're not gonna have that bug identified right away. Some labs are super quick. At BAMC, typically in a day or two, most of the time in a day, we had our bug back. We knew what we were looking at. Sometimes, and depending on what kind of bug it is, things can grow slower, and so it may take longer for you to actually identify what that bug is, okay? So looking at that, understanding that's kind of how you'll say, I don't know what I'm dealing with, this is how you kind of are figuring out what you're dealing with. And then looking at your gram-positive versus your gram-negative, thing that I wanted you to understand about our gram-positive was that thick layer, right? That thick peptidoglycan layer. This is what some of our drugs are going to be targeting, so we're going to look at that. And then you have your gram-negative, which has the thinner layer that's going to be in between those cell walls. So kind of remember, as we go through this, when you're looking at our drugs, kind of when you're looking at the spectrum, what they're looking at. Okay, this is just a quick reminder of your gram-negative and your gram-positive bacteria that you have, and kind of saying, all right, when I'm looking at something that's gram-negative, I need to know that my drug has gram-negative coverage. These are the bugs that are typically covered. When I'm looking at my gram-positive, my drug has gram-positive coverage. These are the things that I'm typically looking at. So when we go through this, for your gram-negative, I'm gonna make sure, because I'm gonna start writing your exam, but I think I'm just gonna tell y'all if it's gram-positive or gram-negative. I'll let you know, because I don't typically do it, but I'll let you know, okay? Because ID is gonna make you remember all of this stuff when you go through that class, and so I don't know if I wanna make you do it yet. I'll look at it. Okay, our pathogens, before we go to our break. We talked about these already, right? You have fungi, you have your parasites, and you have your viruses. We treat these things differently. If somebody is coming in with a bacteria, that warrants an antibiotic. If somebody comes in with a fungus, you don't give them an antibiotic, you're gonna give them an antifungal. If somebody has a virus, colds are the big ones that patients are gonna come into you complaining about all the time, and they're gonna want a medication. And you're gonna look at them and you're gonna say, I'm so sorry that you don't feel well. You can take some Tylenol, you can take some ibuprofen, but I cannot give you an antibiotic because you have a virus, okay? Patients save meds all the time because they think, well, when I get a cold, I'm gonna use this antibiotic that was for this respiratory infection that has nothing to do with their cold, okay? So people do this. Your older population, they definitely do it, okay? Younger population, we usually just forget to take stuff because like we're doing other things. Like, oh, I feel better now, and then they'll leave it. And then they'll get sick again, and they'll be like, oh yeah, I remember I had that, blah, blah, blah. And then they'll take that out and just use it, okay? So looking at what your bug is, an antibiotic does not go to every single type of pathogen that we can have, okay? Each pathogen, if we have something to treat it, has its own class. So antibiotics for bacteria, antifungals for fungus. We have antiparasitic drugs for our parasites, antivirals for our viruses. And this picture, before we do our break, is telling you that typically we have flora. We have our normal flora that's on our skin, that's in our gut, in our mouths, right? We have everything in our products, as I call them for my kids, in our products. We have them everywhere. When we take antibiotics, right, sometimes it may wipe out our normal flora. And that is where you typically see that diarrhea adverse effect happening to a lot of our patients, okay, that side effect happening. So just make sure that with this picture, what I'm wanting you to know is that antibiotics can alter the balance of your normal flora in your patients. If somebody is immunocompromised, this normal flora can potentially cause them to become sick, right? Because they don't have the normal defenses. So now those typical bacteria that we have on our bodies is now causing them to become sick, hospitalized, all of the things, needing potentially an antibiotic. And then understanding that it depends on where it is. This is not to say that these bugs in these areas can't translocate and go somewhere else, because they can. And depending on what type of injury sometimes patients have, you can have bugs in places where they were not supposed to be. But typically, this is telling you, hey, my strep is here, my staph is here, like, where are these bugs typically located? I have had some students, I don't expect for you to remember all of these in this picture from when my mom was probably in school. This is the whole picture. It does help some students where they will try to say like, oh, staph is in the nose, and then they will try to say, these are the different drugs that can go to this area. I don't remember things like that. I remember it based off of the clinical use. Trying to remember all of these bugs is gonna take you a long time to remember exactly where they stay. Again, you will see this again. If you want to use this as a reference as you're going through your slides to say like, okay, this bug is typically here, let me see, oh, it's in their throat or it's by their mouth area. Oh, that's why we use this for pharyngitis. Oh, that's why we're using it for this, because my drug has that spectrum. You can use it for that. It's up to you on if you want to remember this. I'm just showing you the picture to say, hey, we have these things that typically colonize this area, okay? All right, let's take our break and then come back. So 11:03.
Like, I'm not saying you're wrong, but like 6'7", but like you're probably the dude too. Oh yeah. So Tom is what they did like.
The first snap, that's pretty much it. We're not talking about it, that's pretty much it. 6'7". That's why it's a lot.
No,
Seal. No, there was seal. Someone liked it.
What'd you say when you gave it off this?
Knowing the class is like the biggest thing. So you're all, so
She said it was your game.
yeah, like the entire slide deck was no, there's basically no slide. Just like VH on board for like interview. She's not the one now that anyone she doesn't know. Stupid incident. So, like she got a message from like actual SAPD, but it's like well, here's the thing that like when she was going through the whole thing, like she got put trying to make a report with social security administration, but it says on one side by what there is a until like something happens like there's for all they're going to go like they're trying to insert the word because that's all I know, right? Like how you find it, like so like address when you expect your credit score. Social little hard. They have to. So you're going to go to all the strike, right? And then yeah, when I made a report on them, they said that you can't do anything until the fraud is submitted, which is stupid. So one thing that she could do is get like security over it and free credit.
You wait for that guy? Throw it to fucking Marvin. He's probably saved that with him up.
a summary slide for you to kind of check yourself and say, hey, as we're going through all of these antibiotics, am I understanding what the main bugs are that I'm killing? Okay? So when I'm looking at this, my penicillins, my carbapenems, right, I have all of these different drug classes that we're gonna go over. You're needing to make sure that I'm saying, like if I say, oh, we have this gram-negative bug, don't pick something that only covers gram-positive, right? Because I can't pick my vancomycin or use it alone because it's not gonna cover my gram-negative, right? Because it's only gonna cover gram-positive. So when you're looking at this side is all of your antibiotics that you have, like our different classes that we're gonna talk about. And then this will group and say, hey, this is what it typically covers. And again, just like we were talking about, sometimes I can use two of these medications together, two of these different classes together to get the gram-positive and the gram-negative that I want, or more gram-positive or gram-negative. If I'm worried about resistance, I can also put some of these together and kind of like stack them on top of each other, all right? So a good summary slide again for you to kind of review as you're going through everything to say, hey, where does this kind of belong? What coverage am I getting from this drug class? This is also why I told you to remember it by drug class, because you see, if you remember what all of your penicillins are, you're kind of understanding what coverage you have. If you're looking at your bank, you understand what coverage you have. You're looking at your sulfonamides, you understand your coverage. So that's why I was telling you to kind of group them that way, because you get your coverage, and then you're also gonna get your mechanism of action covered with this, okay? This is another spectrum chart that is good for you to kind of hang on to and see. I just want you to focus on the ones that are in the red boxes, not the MSSA, because there's lots of different drugs that are covered by MSSA. But like when you're talking about your vancomycin resistant medications, your MRSA, your methicillin resistant, Pseudomonas, those are bugs that are very hard for us to treat, we do see them. So I want you to remember, like, okay, if I'm looking at a drug and I tell you that there's VRE, then you need to be like, oh, I can use daptomycin or linezolid to combat that particular bug. Again, don't worry about this one because that's too many. So just ignore this red box. And then looking at your pseudomonal coverage, there'll also be some summary charts that I give you that will say, hey, these are all the drugs that cover MRSA. These are all the drugs that cover Pseudomonas. I just didn't do them for every single one. But you want to know what's going to cover Pseudomonas. Your anaerobes. Anaerobes are they're kind of tricky sometimes, and so I wanted you to remember some of the things that we have to cover anaerobes, and then your atypicals as well, because again, they're atypicals, and it's kind of harder for us to treat them. So your red boxes are the ones that I'm wanting you to focus on. Don't worry about your MSSA as much, okay? This will be hit when we go through the slides, but I know a lot of people like to use this versus all of the words that are on the slide to see it as like a snapshot, okay? So only the red boxes, not including MSSA. Okay, our antimicrobial stewardship. This is what I've been talking to you about, and this is where your job becomes very important. You are not going to be shaken when I come into, you see me as your patient, and I'm like, oh, I have a cold, and I feel so sick, and I feel bad, and I need an antibiotic right now. You're not gonna care. You're gonna say, hey, not that you're not gonna care. You're gonna say, hey, I am going to take care of you with giving you a prescription for some ibuprofen, I can give you a prescription for some Tylenol, and you're gonna educate me and say, you know, you have a virus. We don't have any medications that can treat this cold that you have, but I can treat some of the symptoms that you're experiencing from that cold. I cannot give you this antibiotic because you don't have any bacteria that we're trying to fight. You're just gonna experience a lot of side effects from the medication, okay? So you have to educate, don't just say no, don't just give them ibuprofen and be like, yeah, I'll prescribe you something and not tell them, because when they get to the pharmacy, they get mad at us. No, they were giving me an antibiotic. Well, they did not, okay? So keep that relationship, make sure that you're explaining things so that they also know how to maintain good antimicrobial stewardship. So when we're looking at that, we want the right drug, we want the right dose, the right time or duration, and the right route of administration, okay? If I'm not giving it the correct way, again, we have that same problem where it's not gonna get where I need it to go, okay? So just remembering that all of these things kind of come into play for us to make sure that we are being good stewards of prescribing antibiotics, okay? Don't give them to it, like if you look up a dose of a medication that says treat them for 5 days, treat them for 5 days. Don't give it to them for 7 days, don't give it to them for 10 days, don't give it to them for 2 weeks. If it says 5, give it to them for 5. That is helping us close our playbook, right? That bacteria, the longer we give it to them, the more we have our book open. The more that it can try to say, all right, how can I become resistant to this thing that keeps killing me? And so then it starts to alter itself to combat our drugs that we have. So we do several studies and we're like, okay, what is the shortest time that I can have a patient on this medication? So that's how we got our durations. We did studies and we're like, we are effectively killing this bug in this amount of time, that's why we have 5 days. It's not beneficial to add 7, to give them 2 more days, okay? And then if they come back after you gave them that 5 days, you should start thinking, maybe this bug is resistant. Like the one that this person has is already resistant to this drug. And then you're like, all right, what's the next thing, okay? So typically, you're following what is in that drug monograph that's gonna tell you for this indication, you're treating for this long. For this indication, you're treating for this long, okay? We want to have it for the shortest amount of time possible so we can close our playbook back up. In and out. So we already talked about this, like if it's not indicated, don't treat with an antibiotic, right? And then looking at our empiric treatment. When we start with our empiric therapy, we already said we're gonna have more than one. We're probably gonna be broad spectrum. We're trying to cast out that big net. And then when we get our labs back, we're like, okay, this is where I am. I'm operating just within this window. I know that I have this bug, I isolated it, this is the drug that I'm using for that, okay? So that's what we call de-escalating their therapy, okay? So when you're picking your med, you're trying to pick the med that is likely to cover the bugs that you think they were exposed to in that incident, okay? Most of the time we don't know exactly what's causing it. Like you'll have some people who they may have been in water. And now we're trying to think about, okay, well, what bugs do we typically have like in a lake or the pond that they could have been in? Because now we need to have some broad spectrum coverage for those bugs that were in that area that they were in. So it's you being the detective. You're Sherlock Holmes when it comes to antibiotics and trying to do your broad spectrum, and then you're gonna de-escalate, okay? So that's your de-escalation there. And then our IV to PO. Again, your IV department will typically have a pharmacist within it who this is what they're focusing on, but it's also your job as well because they're focusing on one person focusing on an entire hospital, but you have control because you're touching your patients typically on a daily basis. So when we're looking at this, your IV to PO, most of the time we are gonna start with an IV medication, okay? Not every single time. In our more critical cases, more serious infections, we start with an IV medication. And then you try to convert them. Once you start seeing that white count go down, their fever, they start to look better. If there isn't an oral medication that is compatible, we will then switch them to that oral medication. If I can pull that line out of them or stop infusing medications, that's better, okay? You want them to be back to their normal habits as soon as you can. So IV to PO is a big thing. There's several different protocols at different hospitals. They may say like, oh, they have to not have a fever within the last 24 hours. They have to not be vomiting in the last 24 to 48 hours. Because, right, if I take you off of IV and I give you oral meds but you're vomiting, that's not helping, right? Because I'm gonna vomit up my medication and therefore you're not gonna be treating that bug. You're not gonna be killing that bug. Okay, so you would look at your protocol at the hospital that you're at to say, do I give this or do I not give this? Do they meet protocol for me to now take them off of this IV and give them PO? If they're in a coma, you cannot give them PO meds because they can't swallow it. We have people who do this, I'm just telling you, okay? Don't try to convert them because they can't swallow their meds, they're not awake. And then we already talked about the shortest duration as possible. When you're looking at the possibility of having a treatment failure, my patient is not responding to my meds. I don't see white counts getting any better. I don't see this fever getting any better. My patient is still like they're lethargic, all of the other things that are happening to your patient. And you're like, what is happening? Why isn't my drug working? That's when you can kind of start saying like, all right, is there something else going on? Is there resistance? If it's an outpatient situation where you're giving them an oral med, are they actually taking their antibiotic? Are they taking it how they're supposed to take their antibiotic? Because it matters, right? Because if I am a concentration dependent, did I take that dose when I was supposed to kill those bugs and then come back down? Or if I'm time dependent even more, like am I at the right interval to maintain my time over that MIC? Because the longer that I'm below that MIC, the more that bacteria is growing. And now I'm at a loss, right? I'm likely to have treatment failure because my bug has now gotten to continue to grow because I'm not taking it the correct way, okay? So there's that, and then there's also the fact that maybe our lab missed something. So we pull labs, and you'll continue to pull labs sometimes when your patients are in there and they're not getting better. Now, it's a little bit more difficult because you have these antibiotics in their system, but you're hoping like maybe now that load of something else is higher, and maybe I can isolate something else, okay? So you keep snooping until you figure out what's going on. Typically 2 to 3 days, you should be seeing some results. Sometimes it's like 24 hours, but definitely after 3 days, if you're not seeing any resolve, there's something else there that was missed, okay? You can't find it, get an ID, they love to do stuff like that, they'll help you find it, okay? If you fail to practice good antimicrobial stewardship, you not only fail that patient, but like us as a medical field, we have issues because then we start to see all of these things occur, right? That infection can persist. You can have where there's resistance that is now being confirmed because the bug has like decided to mutate to now defeat my drugs. The side effects that you can have, whether they are because we gave too much of a dose, whether we gave it too long, whether it was just the nature of that drug, like when we talk about some of like our clindamycin and then looking at our interactions. Am I giving something synergistically or am I giving something that's antagonistic? Are they working together, which is typically what we want to see versus them not. Also, our antibiotics will have interactions with other medications that they may be taking for another condition, okay? So you have to look at all of these things to say, am I giving this medication without harming my patient and to get the best result possible? This is talking about the resistance. What I want you to know here is the innate versus your acquired resistance. So when we're looking at our innate resistance, that's like I was inherent, like this is my birthright. Like I'm naturally resistant to whatever that medication is. And when we're talking about this, we can look at the example of our aminoglycosides against an anaerobe, okay? So our anaerobes, the mechanism of action for my aminoglycoside is to interfere with that oxygen transport. If I'm an anaerobe, I don't care about oxygen. I don't need it. So therefore, your anaerobes are inherently resistant against aminoglycosides because the aminoglycoside target is not present in that anaerobe, okay? So that's like an example of innate resistance. I was born this way, so I am resistant to this drug. Your target is not needed for me to survive. Whereas my acquired resistance, there was some type of mutation, adaptation over time. You left your playbook open to me, or several people in the community have brought back this bug from somewhere else, and now we have this acquired resistance against my drug. Now my drug is ineffective. My bug mutated to become smarter because it studied my playbook, and now my drug doesn't work. Okay, so that's your acquired. So innate, where they started, like that's just naturally how they are, versus your acquired, they acquired it over time. They mutated to be able to do that over time. And then we talked about our stewardship already. So if I have poor antimicrobial stewardship, I'm likely to see this, but also if my patient is not taking their meds how they're supposed to. if I only took half of it, right? So now I opened up that book and the bacteria is like, okay, so now whenever I stop taking it for 2 weeks and I get sick again because that load went back up, and I come back to you and you prescribe me the same thing, the bacteria is like, we just saw this 2 weeks ago, not gonna work, because you showed me this already, okay? So that's how we get that acquired resistance, okay? And then we talked about this a little bit, like our resistant to at least 3, our MDROs, understanding also why we have hand sanitizers and sinks in almost every patient room in the hospital or before you're walking into the room. Think about being in an ICU. These are our sickest patients. They're also sometimes our most immunocompromised patients, depending on why they're in there. You go from one room to the next room, and you forget to wash your hands. You have now taken that bug from the other room and put it into this room. And now they're double teaming your patient and also causing resistance to more things, okay? So hand hygiene is a big part of us also making sure that we're not increasing the resistance that is happening, okay? Because the drugs, those bugs are smart. Our drugs, we're trying to catch up. This is just a picture showing you of how you can initially have a few bugs that are resistant to our drug, and then over time, as they do their resistance mechanism and they transfer that DNA to their friends, right, the other bugs, then you can see where you have more drug resistance, and now that drug is not likely to overcome that resistance. We may have to, have synergy, or come and pull out one of our bigger guns that we want to try to reserve. Yes, we have broad spectrum drugs that are very good at killing some of our resistant bugs, but the more that we use those, the more that those bugs will now start to become resistant to those big guns that we do have, okay? So you're kind of trying to balance the two and make sure that we reserve those bigger things until, like, for when we need them, okay? All right, this is looking at resistance. So this is how my bugs are saying, thanks for telling me your playbook, now I'm about to be smart and your drug is not gonna work against me, okay? So when we look at beta-lactamase production, you have beta-lactams, which we're gonna get more into, bless you, and we have what's called a beta-lactamase. What your beta-lactamase does is it will say, hey, beta-lactam ring, chomp, and it will cut it. And now your drug doesn't work, it's ineffective. So our bacteria are making beta-lactamases. That is their form of resistance against your beta-lactam drugs, okay? So they will make this beta-lactamase, it'll kind of spread it out, and then whenever that bug is trying to come, whenever the drug is trying to come to that bug, it's like, nope, 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 it has a defense, okay? Most of your penicillins will be knocked out. Most of your beta-lactams are knocked out. So most of your penicillins are gone. Your cephs, your carbapenems, your aztreonam, which we'll talk about that, these are like not going to be effective, okay? We lost them. Whenever you see a beta-lactamase coming for your beta-lactams, it's not a good day, okay? So when you look at these, you have different types of beta-lactamase resistance, which is going to be your ESBLs and your inducible AMP-C. The inducible AMP-C, you'll see this with some of your drugs to where like you will give the drug and then the body isn't initially like the bugs aren't resistant to it. But as you continue to give that drug, they're like, oh, I don't like that. And then they start to make AMP-C to kill your drug, to make your drug inactive. So that's why we call it inducible. And then you have your gram-positive resistance is going to be MRSA, which a lot of us have heard of MRSA. But your methicillin-resistant Staphylococcus aureus is MRSA. Okay. So when I'm looking at gram-positive, gram-negative, I can make beta-lactamases to inhibit your beta-lactams from working. I'm going to cut that ring. Whereas whenever I'm looking at my gram-positive beta-lactamase, I have specifically MRSA. We're looking at our ESBL. So in these these couple of slides, right? This mechanism, I don't care that you know that. It is for your information. I want you to see, if I told you ESBL resistance, you're like, my drug of choice is carbapenem. And for this one, I also want you to only remember the bowls. The other stuff is down here because these are other things that can be used, and you'll see them when we go through the slides. But on this, I'm focusing on, if you see I said something had ESBL resistance, I want you to be like, oh, I need a carbapenem. Okay? So those are the only two things you're worried about from this slide. ESBL, carbapenem. Okay? When we're looking at our AMP-C, remember I told you that that was inducible. So anytime you're looking at your AMP-C, I want you to remember cefepime. Again, these are other options that you have that you can use in that situation, but I want you to focus on the bold. So AMP-C, cefepime. Okay? Don't worry about the mechanism, all of these bugs. These are typically, you'll hear people say, oh, space bugs or spice bugs. That's when you'll typically see that AMP-C being produced by them. It's always being produced, but it can cause problems whenever it's overexpressed. That's whenever they have that resistance, okay? So, AMP-C, cefepime. And then when we look at our MRSA, this one you need to know all of them because you can use all of these typically as first lines. So when we're looking at our MRSA, this is one of the ones that you're gonna see a lot. It's, thankfully, a lot of our drugs still work against MRSA. So when we're looking at this, you have ceftaroline, which is typically not one of the first ones you're gonna go to, more restricted, but we'll talk about that. Clinda, I already told you about Clinda and how we have C. diff kind of associated with it. So again, it's an option for us to use, but not one of the ones that we typically would see. Your daptomycin, doxycycline, linezolid, Bactrim, which is your trimethoprim sulfamethoxazole, is also called Bactrim, and then your vancomycin. What I did as well was I put in the routes because depending on the setting and how your patient is admitted will depend on sometimes the drug that you choose. I like to choose the drug that has an IV and a PO option because remember we're supposed to switch them from IV to PO when we can. So it's a lot cleaner. Now, sometimes you'll get those lab results back and that bug may be resistant to that drug that has the IV and the PO formulation. So you're kind of getting stuck. I'm not gonna ask you IV versus PO. I'm gonna ask you, hey, do you know what covers MRSA? Do you know what drugs we have to kill MRSA? So again, MRSA is what you're looking at, and then all of your bolded medications, okay? MRSA is your type of resistance that bug is making, and then you're trying to combat it with one of these drugs, okay? Your drug of choice. Okay, somebody tell me what prophylaxis is. Preventing, right? So I'm giving something before. If I have a scheduled procedure, whether that is, I know that I'm taking somebody to the OR, whether that is they're having a C-section, a dental procedure, any of these things can qualify and say, hey, I need prophylaxis. If I'm deploying somebody somewhere, sometimes we put them on prophylactic medications, right? They should be taking it prior to them going, while they're there, and when they get back. I'm trying to prevent them from getting some type of disease. So when I look at this, what I want you to remember is just down here, you have your two types. You have your surgical and you have your non-surgical. When we're talking about our surgical, those are any types of surgeries that a patient could have where I want to prophylactically treat them with an antibiotic prior to them having that procedure. I'm trying to prevent that bacteria from dislocating from one spot and going somewhere else and potentially causing an infection, okay? When you look at prosthetics, those are very, very, because it is a foreign object that we're now placing in someone's body, a lot of things like to stick to them, and they cause lots of infections and sometimes rejections of that prosthetic that we could have put in. So we try to treat prophylactically to prevent that. And then you see your non-surgical prophylaxis would be, like I told you, those deployments or how we talk about PrEP. Like if a patient is in a discordant relationship, one patient is HIV positive and their partner is not, we know how we can put them on antivirals for that. So again, that's prophylaxis. Prior to somebody actually getting infected with HIV, we can treat them to try to make sure that we can keep that virus out, okay? So just understand that there are two different types of prophylaxis that we have, and the idea is that they're taking it prior to them having whatever that disease state is that we're trying to prevent, or infection. This is just an example. You're gonna see this again, so you can refer to this, but it'll also be on slides. This is like a little quick summary of it. But when you're looking at the type of infection, so this you're looking at endocarditis, you have wound infections, abdominal infections. Based off of what that pathogen is that is typically in that area, I can now say, here is the preferred drug that will cover that type of bacteria, whether it's gram-positive, whether it's gram-negative. So, with my endocarditis, I have my amoxicillin or my Clinda, and then your wound infections, you have cefazolin. So typically before we do a surgery, you'll see a lot of cefazolin is like their favorite, that you'll run, like that they'll have running prior to them cutting on that patient. Depending on how long the procedure is, the time that they start running the cefazolin will vary. And then you have your surgical abdominal infections. We have several different options. So again, we're gonna see this. Again, it's just like a summary slide, summary chart and examples for you to see some of the drugs that we're using as prophylactic drugs. Okay, check on learning. In which non-surgical scenarios can I use an antibiotic to prevent something from happening to my patient? Prophylactic. All of them, right? So my dental extractions, most of the time we're very worried about these with our patients who have artificial heart valves and things like that, because that bacteria will dislocate from their mouth, which we have a lot of germs in our mouth, and then they will go to their heart and stick there and build plaques and can potentially cause endocarditis, okay? So, all of the above. All right. I like pictures. This is a picture. You can use it or you cannot use it. This is essentially giving you a summary of all of your mechanisms of the drug that we're going to talk about, okay? So it's telling you like, hey, this is where this drug is working, this is where this class is working, and then you can go in and you can be like, all right, what are all of my beta-lactams? And it has them listed here, and then you can go and say, okay, well, what are penicillins? And now you can write more drugs that are penicillins. All right, what are carbapenems? And then you can write drugs that are carbapenems, so that you can have everything on one page. I like stuff on one page, okay? You can also use this to say, all right, what are the typical side effects that I'm seeing for these things? And you can write them there as well to try to put it, I had mine on the back page so that I wouldn't, so I flip it over because it wasn't enough room. And then I would write, here are the side effects for this class. For my carbapenems, I typically see this. For my cephalosporins, I typically see this. For my penicillins, I typically see this, okay? And you can kind of group them together, and they group together very, very nicely. So again, when we're talking about the classification of these drugs, they're based off of essentially their mechanism and where they're working. So your cell wall synthesis inhibitors are inhibiting your cell wall from being formed, okay? When I look at my DNA gyrase inhibitors, it's affecting your gyrase. So all of these are telling you what your mechanism is for those drugs, okay? So that's what this is showing you. In our immunocompromised patient, which antibiotic did we like? Cytal, because I'm not strong enough to fight it myself. All right, look at my cell wall membrane synthesis inhibitors. You're gonna see a big thing like this so that you can remember what drug classes you're looking at. So I went through and I was like, okay, this is so that you can remember you're looking at cell wall and cell membrane inhibitors. And then there will be a divider like this every time you switch to a different mechanism of action, essentially, okay? So, breaking that down even further, because I said cell wall and I said cell membrane, two separate things. So when I'm looking at my cell wall inhibitors, you see I have my beta-lactams and I have my glycopeptides and my bacitracin, he kind of falls in there, but it's a little weird. So then I can see all of my different beta-lactams that I have, okay? And we're gonna go through all of these. So we'll look at our penicillin, cephs, carbapenems, monopenems, which is our aztreonam that we talked about a little bit earlier. And then my glycopeptides, my vanc and my telavancin. And then my bacitracin is one that's super common, we can get it over the counter, but it's also working on the cell wall, okay? When you're looking at your cell membrane, these are all the things that are focusing on the membrane. Do not get these mixed up. People always get these mixed up. Cell wall and membrane are two separate things, okay? Different targets. So your cyclic glycopeptides, which is your daptomycin, your polymyxins, which we'll talk about again, is your polymyxin E and your polymyxin B, okay? Now, when I talk to you about this mechanism of your cell wall inhibitors, we're gonna use these a lot. People use penicillins a lot, people use cephalosporins a lot. This is one of your highly prescribed drug classes that you're gonna use. So, we talked about our gram-positive, how we have that peptidoglycan layer here, and it's thicker in my gram-positive than whenever I'm in my gram-negative. So that outer membrane that we have in our gram-negative isn't found necessarily in our different, our other bacteria that we have, okay? Because here is our membrane when we're looking at it, our plasma membrane for our gram-positive. Whereas here, we have an outer membrane and then we still have that plasma membrane, okay? So your cell wall, it's easier for me to target that and look at that peptidoglycan layer when I'm looking at my gram-positive, it's more exposed. You'll also see LPS, which we'll talk about a little bit, so that lipopolysaccharide layer that your gram-negatives have. We're going to look at that. We'll also look at some of these PDPs or your penicillin binding proteins because our drugs are going to try to target them and say, hey, like, I'm trying to stop this from forming, therefore I can damage your cell wall. So, our beta-lactams. When we look at our beta-lactams, most of the time these drugs are they're bactericidal drugs and they're time dependent. What did it mean for time dependent? My time above the MIC was more important than my dosing, right? Of how big the dose was. So time dependent killing and bactericidal. I'm taking them out, okay? Looking at my mechanism of the resistance. So what can my bug do to make this drug ineffective? My bug can make a beta-lactamase to chop up my beta-lactam and make it not work, okay? So the beta-lactamase inactivates your beta-lactams, which is this drug class that we're talking about. So if a bacteria makes that beta-lactamase, it is going to be very hard for your drug to actually work because now it has something cutting it up. Think about Pac-Man, okay? Then looking at this renal excretion. So what am I worried about? If I'm a renally excreted drug, now what are you worried about as the provider? Your GFR, my creatinine clearance, what does your renal function look like? Because if I know that there's something wrong with your renal function, I might need to adjust my dosing for my meds. Also, sometimes when you have patients who are in ICUs, their renal function is changing because they're hurt, they're sick, okay? So depending on what that renal function looks like, you may have to dose more frequently, you may have to dose less frequently. Look at your renal function, check your renal function. And then, so this is our drug class, and then here are some other medications that fall within that class. So I have penicillins, cephalosporins, my carbapenems, and my monobactams. I keep repeating it so that you can remember where are these things falling. So your big umbrella is a beta-lactam, okay? So this is my group. And then I'm saying, all right, what falls under beta-lactams? So then that's where then you see the penicillins, your cephs, your carbapenems, and your monobactam. Then you can then say, okay, what are penicillins? Because there's different types of penicillins. Then we're going to say, what are cephalosporins? Because there's different classes of cephalosporins, okay? So if you were trying to draw this out, beta-lactam would be at the top, okay? And then you're going to say, all right, I have penicillins, I have my carbapenems, Okay, so then make your umbrella and then continue with, all right, here are all of my different penicillins, here are all of my different cephs, here are all of my different monobactams, and so on and so forth, okay? So, when we're looking at our cell wall inhibitors, they're doing that. They're inhibiting the cell wall. So, what you would see is like your beta-lactam antibiotics are gonna look at these PDPs and they're gonna inhibit them. What your PDPs are doing is they're helping with the formation of the cell wall. So remember, I'm trying to inhibit the cell wall. So if I target that PDP, I'm preventing that cell wall from being constructed properly, all right? So they're targeting their PDPs. So when you look at your beta-lactams, they covalently bind. Remember when we have those covalent bind, like any covalent binding, sometimes it's very hard for us to reverse that, right? Especially if it's been like that for a longer period of time. So that's why we see that sidal effect that we're getting from our beta-lactams. And so those cross-linkings that we're gonna talk about a little bit further on the next slide are gonna be prevented. So my beta-lactams are binding to my PDPs and saying, I am going to make your cell wall be very weak. It's not gonna be great. And then all of your contents are gonna leak out. And you're gonna die. And then smile. That's your beta-lactams. So, when you're looking at this, what this is trying to tell you is that you have diala in that peptide, in that peptidoglycan layer that we were talking about. Your drug, typically your diala and your diala, they form this cross-linking. Your drug is being an imposter. Your drug is like, I'm gonna act like diala. So it goes in there, and whenever it does the cross-linking, because remember it's disguised, right? So whenever it does its cross-linking, the cell then will incorporate your drug, and then it will have a hole, essentially, in its cell wall, and then ultimately it leads to lysis, okay? So think about if you were like trying to build some type of fort or protection, and you're trying to stack and cross things, right? Your drug comes in there and it's pretending like it wants you to be like this, but instead it's like making it like this, okay? So now you have all of these holes and you're not really protected and everything leaks out and that cell will die. That bacteria is gonna die, right? So diala cross-linking your drug, your beta-lactam is in disguise. And it gets cross-linked in there, and instead of forming a tight cross, it's making a loose cross, and then you have the lysis occur. Our first class that we're going to talk about is going to be our penicillins, okay? So we're still in cell wall. We're still inhibiting the cell wall. Your mechanism is still the same. So we just talked about that mechanism, right? I'm binding those PDPs. I'm making myself into that diala crosslink. I put myself there. Aha, I gotcha. Now we got leaky cells. Now we have lysis. Cytal activity, was I time or concentration dependent? Time. Did I have to worry about my renal function? Yes. Okay. So when we're looking at this, I'm a natural penicillin. You have different types of natural penicillins. Your anti-staph, and then you have aminopenicillin, anti-pseudomonal penicillins, and we're going to talk about these. And then we got smart, and we said, okay, bacteria, you're making beta-lactamases, I'm going to make a beta-lactamase inhibitor. So now you have your beta-lactam, which is getting attacked by your beta-lactamase, right? And then we were like, hold up, we made a beta-lactamase inhibitor, so now we are back on top. We're now more resistant to those beta-lactamases that were being made by the bacteria, okay? So your beta-lactamase inhibitor is stopping the thing that was eating up my drug. It was stopping the beta-lactamase. I don't like beta-lactamases. I want to beta-lactam it out. And I can't if the beta-lactamase is chewing up my ring, okay? So we said, I have a bigger gun, I'm going to make a beta-lactamase inhibitor. Right? So that's what you see. We add those to different drugs, different ones of our penicillins and some other drugs as well, that are going to be in our cell wall inhibitors, and we will let those live a longer period of time. so that when those drugs are making those beta lactamases, we're kind of more resistant. It lets us last a little bit longer. Okay, as we go through these, I will also have this up again so you can see what we're focusing on. And they will be in like the red box. Am I expecting for you to remember every single bug that these? No. Remember, we're focusing on the red box outside of our MSSA. Okay? I'm just highlighting this is the area that we're talking about right now. So if you see this snapshot, you see that your penicillins end in cillin, right? So that should be a good hint for you. Your penicillins are ending in cillin, and then you see that they have pretty good coverage. I have some gram-positive coverage. I have some gram-negative coverage. It's giving great drugs, okay? It's a good drug. We like them, all right? But you see a lot of our stronger things that I was telling you we have problems with, we don't have that coverage with our penicillins. So like if I'm looking at my MRSA, my BRE, if I'm looking at my atypicals, I have gaps. Only with my Pip/Tazo or my Zosyn do I have pseudomonal coverage, okay? So my bigger issues are not covered so much by these drugs. Kind of remember them as like, they were like the first ones that were kind of around, okay? So they're not as strong as we would like for them to be. We'll get down here where we start to make stuff where we're like, all right, we got bigger bugs, I got bigger drugs. But right here, they're not getting a lot of those strong bugs, those more resistant things, okay? Looking at my administration, I have several routes. That's what I need you to remember. I got IV, I have PL, I have IM. Anytime you see IM, sometimes specifically dealing with our antibiotics, yes, I may be giving them like one injection, but it may be distributing over a very long period of time, okay? So that's what we're looking at when we look at some of our IM. It's like a sustained release. The injection is gonna hurt, but they only have to deal with that one time that they take it, okay? Because it's gonna slowly distribute. Looking at your absorption. Uh-oh, y'all. Can you see what's going on? Looking at your absorption. When we talk about food, it varies because I sometimes will tell patients if they're like, oh, my stomach hurts, and so I'm not gonna take the med. I would rather them have sometimes decreased absorption to have something versus them not taking the med at all because their stomach hurts, okay? A lot of people are gonna complain of GI upset, but if they eat and then they take their med, we can expect to see a decrease in our bioavailability. The only one that we don't see that with is amoxicillin. Amoxicillin gets an A+. I can eat, I can be happy, and I can take my med, okay? So, any of the other ones, if your patient, they should be taking it on an empty stomach. If they tell you that they cannot take it on an empty stomach, they can have it with food, but just understand that you may have a decrease in the bioavailability of that drug. Sometimes it's not enough to where you have to increase the dose, and you won't experience the treatment failure. But we definitely, because we said, hey, I want to be above that MIC as long as possible, I need to get that drug in there. So we tried to tell them no food except for amoxicillin. When you're looking at your oral administration, this is very good for us to see that I am absorbed whenever I'm talking about being in the GI tract and being able to be absorbed. A lot of the times, because of that, we'll use this in a lot of our GI infections that our patients may have. Because I'm gonna sit there and I'm gonna get absorbed, I'm at the site of infection, okay? So we do have some meds that do not get absorbed, and we use them in different ways. We'll talk about some of those as well, okay? So without food, bless you, without food except for your amoxicillin. Looking at our distribution, if you have someone who is pregnant, breastfeeding, they're gonna have, the fetus will have exposure to that medication. But what you see is that you don't have teratogenic effects, it's just letting you know that it's getting to that fetus. So again, patient, provider conversation, if they don't want their kid to be exposed to any antibiotics, we have to respect that and see if we can find something else for that patient. When you're looking at your penetration to your CSF in your bone, hey, inflammation inflammation is good for us. It's kind of forcing it into those tight areas that are kind of protected. We're using the inflammation to our benefit to get our med to where we want it to be, okay? And then looking at your excretion, we already said we have renal excretion, therefore I might need some renal adjustments except for NOD. Your nafcillin, your oxacillin, and your dicloxacillin. The reason why we don't care about those in a patient who is experiencing any type of renal issues is because they're excreted through the biliary system. So we're not worried about any renal issues. So NOD. Those are my penicillins that I don't care if there's any renal issues, I can safely give them and expect for them to go through their body perfectly fine. So, I have a patient with renal dysfunction, NOD. Okay? Last one that we'll look at today will be our adverse reactions. So, most common adverse effect that you're gonna have people say is that they have the diarrhea. This is what I was telling you that people will also say is their allergy and not their allergy adverse effect. Those antibiotics are great. They're gonna go in and they're like, you are bad, I'm getting rid of you. They can't tell the difference between our normal flora and our bad flora. Remember we talked about that selective toxicity? We're trying, but we're not perfect, okay? So it's gonna get rid of those bugs, the bad ones that we didn't want, or the overgrowth of the normal flora, but it also wipes out the normal flora. So what we tell our patients typically is you can tell them to eat yogurt, and that yogurt will replace those natural flora that are in there to where they won't have that, the diarrhea. Okay, so it limits it. We also have something that's called Flora Store that you could give patients to kind of put back the good bacteria that they have, and it avoids the diarrhea, okay? You also see if I were to give somebody a very high concentration, typically if I were talking about like my IV doses, I can see seizures occur in my patients because remember I can cross. And then looking at my hypersensitivity. This is where we would have our patients saying they're allergic. And we have those some false claims of allergies. When you're looking at hypersensitivity, you see that it's not as common to have a true penicillin allergy. This number always changes, but it's not very common. You do have a lot of people who will have hypersensitivity, like they're having a little rash or something along those lines, okay? So you see that morbilliform rash is the most common reaction that you'll see on their skin, and you see he just looks super uncomfortable and the rash is all over their body. And then you have your angioedema and your anaphylaxis. This is that, but did you die though? Almost in these patients, okay? Their tongue will swell up really bad. Depending on how bad that anaphylaxis is, they could go into shock. Like their blood pressure and everything drops. It can be very, very bad for these patients. So these, you definitely need to make sure that you're annotating if someone has an anaphylactic or angioedema response to using one of your penicillins. Very rare, but it is very serious because they can die, okay? And then your cross-reactivity typically we'll say is less than 5%. And when we say that, cross-reactivity, so if I said that I had an anaphylactic reaction to amoxicillin, which is one of my penicillins, I wouldn't tell you to like just throw me on a cephalosporin, right? Because I could potentially cross and have that anaphylaxis happen if I use the cephalosporin as well, okay? So, rare, but it can happen, and we have ways to get around that. So we'll start here tomorrow, okay? We made it, y'all, we okay.